you BW for this opportunity, and on a solemn note with what Dr. Mahajan and Dr. Lal has brought about, I think there is a need to bring a change into the environment, especially considering the violence which has taken about. I think with that solemn note, we'll move on to the technological aspects and how the technology has transformed the healthcare in the last decade. There has been disruptive innovation in, I think, all aspects of healthcare. And with this disruptive innovation has come challenges, both at the organization level and at the individual level. And more so in our clinics, when we see the patients, obviously the technology has made inroads there. So with the central mantra of the patient comes first, and whatever we do, it has to be for the good of the patient. Let's discuss the technological advancements, and from there also understand the challenges which have arisen out of the technology. So what we'll do is, I, in my head, had the list of panelists. I have gone through their strengths and their area of expertise, and I tried to draw questions from there. We'll go through one at a time, and then we'll take it from there. So I'd like to start with you, Dr. Indu. You are a healthcare leader. You have been in this journey for almost more than 30 years now. You have seen the transition from a cobalt radiation machine to a LINAC. The first question for you I would like to ask is, how has the patient outcome improved?
Good morning, everyone. And first of all, I would like to thank BW Healthcare for having me here. I think that's a very, very important question, because once when I started my journey in radiation oncology in 1996, then we were treating patients on cobalt machines. And what I realized was that many patients were leaving their treatment in between. Say head and neck patients, they would get a woody neck, they would not able to swallow, they would have a very thick saliva. The patients who were treated with prostate cancer, they would have rectal bleeding or urinary bleeding, which would last for years and years together. And because of this, there was so much fear in patients that they were leaving their treatment. But now I would say that few things which happened in the field of radiation oncology, in terms of which I would call them as a disruptive technology, in the sense that they drastically changed the way in which treat patients now. So in a way, three-dimensional conformal radiation or intensity modulated radiation therapy, with these techniques, we are able not just to conform the radiation dose to the area that we want to treat, but at the same time, we are able to restrict the doses to the surrounding structures. Say for that matter, if I'm treating a patient with head and neck cancer, I will protect the saliva. I will prevent the doses going to the parotid glands. If I'm treating a patient with a prostate cancer, then I will prevent the doses going to the neurovascular bundles and maintain the rectal dysfunction. So in a way, for treating a patient with brain cancer, we are able to save their scalp. So with all these things, a lot of innovations came in, and now the patients are not just living longer, but the life is worth living. That is what the difference that I would say has been
done. Having understood that, there has been a considerable improvement in the delivery of the radiation. Now, what is also important is the cost has increased many folds. For example, a radiation which could cost certain sum is 2 to 3x when you change the modality. So how do you go about, communicating to the patient in the most earnest and an empathetic way that, eventually these are the 2-3 modalities which are available to us, and that's the technological advancement which we have made. How does that conversation take place? How does that communication take place?
So I think whenever you're treating a patient, most important is an honest and transparent communication, keeping the financial aspect completely aside. So what the patient needs, what I'm going to do, is it actually going to make a difference in the life of the patient? That is what I think. So like if I'm treating a patient with a brain metastasis, with a solitary lesion, earlier we used to give whole brain radiation, which would cause a lot of neurocognitive dysfunctions. But now we are able to do hippocampal sparing radiation. So we are able to preserve the memory of the patient. So when we explain the modalities, we explain that this is what would happen if we treat with this option and if we go for a higher option. So we have to see if I'm giving any treatment, is it actually going to be cost effective in the long run? If the toxicity that would happen because of a lower modality, will the patient live that much long to have that toxicity? So if the patient has a long lifespan, if the patient is curable, then ultimately if you choose a better modality, it actually leads to the less cost to the patient in the long run. Otherwise, they are spending a lot of money just on managing the complications, and they live with those toxicities for life.
Now, if I understand it well, with each technology that requires a upskilling, I'll ask, most earnest way, being a woman in healthcare, do you think there are differences in the opportunities available for the upskilling between men and women as when you come, when you consider the opportunities available for the upskilling?
So that's a very interesting question. So if this question was asked to me before COVID era, then my answer would have been different. But I think 1 year that could make a difference is something that happened after COVID pandemic. So after that, because of the telemedicine, I think upskilling is not much of a problem these days. On the click of a button, if you want to upskill, you can definitely upskill. But of course, if it's the question of being physically present for upskilling, say like now when we say patients, we say whether laying hands on the patient is what makes a difference versus video and telephonic visits. So it's like that. So if you have to practically go to a place to learn, then definitely women have a little less opportunities, I would say, because of the family issues. But yes, if they want to and they're determined, then family supports. This is my way of putting it.
Right. So, Dr. Prasad, so first of all, I should congratulate you about having a considerable market share of SS innovations in the Indian market.
Thank you.
Now, with that, I would like to understand from you the role organization has to play in professional development of their staff in relation to the new technologies. So essentially, when you bring in a new model, how do you make sure that your entire team gets constantly updated, and how do you make that happen as an organization?
So it's a very good question. So firstly, thank you to BW Healthcare for having me today. Thank you for the opportunity. See, if you just take a step back, look at sort of the evolution of robotic surgery within India, or even beyond that. So, as you know, all surgeons we trained as open, techniques, then laparoscopy, then came the advent of robotic surgery. At every generational gap, everyone was screaming heresy, and I can't believe you're doing this. So now surgical robotics has been around long enough to be accepted. Now I think the biggest problem previously was educating the patients that it's actually, the robot is not working autonomously. It's actually just an instrument in the hands of the surgeon, an extension of their capabilities. So when it comes to training, so because of the major player in the market over the last 20 plus years, the company from the US, the training programs although the rise of it occurring in India was rather slow, and I think that was primarily due to the prohibitive costs. So just taking a step back, looking at disruption through technology in healthcare, if you look at technology, technology is only good if it benefits most. And now, no way should technology be prohibitive in a space like healthcare, because ultimately our goal is to heal the patients. So training is paramount when it comes to that. I think for other robotic surgeons, and I know there's some seated on the stage here today, if they've learned the previous platform, their training and learning curve is very short. For them, it's like driving a different car, because they understand the core fundamentals of ergonomics and robotic operations. But we've launched now 50 programs throughout the country in a very short time, in less than 2 years. And see, every hospital, they'll have a different requirement. So we've not only metro cities, but tier 2, tier 3 cities. And so we launched programs where there were no laparoscopic surgeons. There were only general open procedures that were followed. Lap surgeons, of course, they're some of the hardest to train because they have decades of muscle memory. So they have, the pre-programmed movements that they do day in and day out. From a training point of view, so whenever I go to a new center, I'll divide the hospital team into 3. surgeons, assistant surgeons, scrub nurses, and OT support staff and technicians. So they all have their own didactic training modules, and then they have to do it, but although the surgeon must know all because they're the captain at the helm of the ship. So we take them through a very rigorous, almost 2 to 3 weeks of training. See, our goal, and this is sort of our mantra in developing the mantra system, is that because we're a company that's started by doctors, it's run by doctors, all the input we get on how to improve our technology are from end users who are also doctors, and we work with a team of engineers who are also scientists. So we really want to remain a science-based company, and that translates across not only in our clinical outcomes and very good results, but in how we're training the team. See, as a doctor, it's like when we're training in residency, you know, you always have an attending in the room, and because you know that they have your back. So until and unless a hospital program succeeds, I will not feel like I've succeeded and done my job in training. So training is very important, every hospital having a different requirement, but I do feel that what we've done till date has been successful in the clinical adoption of our surgical robotic platform. And I think that India has an enormous opportunity with an affordable system.
So I'll come to a opportunity that I made. And so to hold the thought, you know, let me bring in the urologist on board. So Dr. VIPIN, urologists have been the front runners when it came to the robotic surgeries. You were the early adapters. And I think just to toss in a bit of controversy, which is your primary robot?
So we, in 2012, the Da Vinci came in India, and we are among the first user of the Da Vinci. And I used that system for 10 years, and 10 years the life of the Da Vinci robot. And then to explore something new, we have multiple options available with us. And with the hospital consensus, we then taken the Medtronic robot, the Hugo one. And I must congratulate the Mintra because that is made in India thing. But somehow the things are not worked up for our...
So what are those things is what I wanted to... So the point
so
is there's a good system available there which possibly has the option of democratizing and going to the tier 2, tier 3, and possibly if it starts from the tier 1, it can percolate into the country. I wanted to understand your challenges and the solutions you see to those challenges.
So once we have decided to transport ourselves from one robotic system to another, we have multiple options and multiple challenges and multiple things which you need to satisfy ourselves. So we have bought this robot about 1.5 years back. That time the Mintra is also is one of the entity. One of the point of going towards the Hugo, because Hugo have more or less the same system of operations as of Da Vinci, as on the console, and the Mintra has a different. So we need to train ourselves. We have to memorize all the things again if we are shifting from Da Vinci to Mintra. Secondly, there are certain things which I believe on my personal basis, maybe I am wrong, that are a bit better as compared to Mintra in Medtronic. And one of the point, I just attended a session before regarding the procurement. Sometimes we believe in a product which is coming from a company which already has been established and has its name. So Medtronic, being the biggest surgical device company, has a brand value. And these are the primary reasons which we opted for Medtronic. One of the reasons not opting Da Vinci again is one, the cost. And the second thing, as a surgeon, I want to explore new things, because if we increase the competition, we will decrease down the cost. So this is the another thought of opting for Medtronic, not for Da Vinci.
Fair. So I'll come back to you in a bit to let you respond. So let me ask Dr. Das. Robotics is making inroads into the orthopedics. What do you think justifies a robotic replacement versus a standard replacement? Do you think the cost versus the benefit of it, is it justifiable? You think it is more of marketing than science? What is your take on this particular part?
Thank you so much for having me here, Business World Healthcare Award and the organizers. Let me simplify things. Let me touch this topic in a different way. We are talking about technology, trust, and healthcare system. Audience, distinguished guest, I would like to ask a simple question. आप किसी भी डॉक्टर के पास जाते हैं, डॉक्टर रिपोर्ट्स देखते हैं, आपको सब कुछ करते हैं, दवा लिखते हैं, दवा लिखने के बाद आपको बोलते हैं ठीक है अब आप ठीक हो जाएंगे. पेशेंट बाहर निकल के बोलता है ये कैसा डॉक्टर है, मुझे तो टच ही नहीं किया, मुझे तो क्लिनिकली देखा ही नहीं है. So हम कहाँ किस एरा में जी रहे हैं जहाँ पे सिर्फ टेक्नोलॉजी बातें करते हैं, क्लिनिकल एक्यूमेन कहाँ गया? So coming to the point, there is a term called cyberchondria. बहुत simple, I know many of you must be knowing. Most important thing nowadays, a patient googling and taking information from the Google repeatedly and getting into a position where there is restlessness, depression. कहीं भी कोई swelling होता है body में तो मैडम would be telling वो कैंसर फील होता है, कहीं भी बुखार होता है तो ट्यूबरक्लोसिस फील होता है. So technology, I'm not against technology, I am against the dependence of the patient and the doctors on technology. So coming to robot, let me make it very simple. I'll come to your point. Suppose एक बार्बर हेयर कट करता है. अब हेयर कट करते वक्त एक ट्रेडिशनल बार्बर वो 20 years से हेयर कट कर रहा है. He is a hair stylist, we call it. So he is cutting your hairs and so beautifully and you are fine, happy. One fine day उसका बेटा आता है और he comes with an ताम झाम everything and he takes a trimmer. So the trimmer starts, he starts cutting with the trimmer. So the same person says, अरे आपके फादर ने तो बाल काटा था, मेरे तो 1 महीने 2 महीने तक पता ही नहीं चला, it was so good. आपने क्या ट्रिमर यूज़ किया और मेरे तो इधर उधर बाल हो गए. So now coming to the point, robot and traditional thing. See, I am trained in everything, robot and all the latest technologies. I have been doing joint replacement for last 18 years. It all matters for a patient कि डॉक्टर साहब मुझे ठीक होना है. अब ठीक होने के लिए आप रोबोट यूज़ करिए, आप नेविगेशन यूज़ करिए, आप ट्रेडिशनल तरीके यूज़ करिए, आपको ठीक करना है, right? For me, if I do a joint replacement surgery, I'm not praising myself, but it is all about the expertise. I can do a joint replacement surgery in 20 minutes. The patient stands the very next day, right? If I use a robot, I'll take 2 hours. So how can I make the patient understand using a robot will lead to maybe infection because I am exposing the patient the wound 2 hours and I'm exposing the wound for 20 minutes. If I use a robot, I'll have to give a big cut. Cost is, I know, a cost would be around 1 lakh or something extra. Patient is ready to pay that. But end result, डॉक्टर साहब आपने तो सारे ताम झाम करे, मैं ठीक नहीं हुआ, मेरा दर्द तो 6 महीने तक ठीक नहीं हुआ. So coming to your point, cost is important, result is important, but final is the doctor-patient relation, guru-shishya relation. आपने सुना होगा पहले वैद्य होते थे, वो पल्स देखते थे और बीमारियों का पता बता देते, भाई आपको ये बीमारी है. आगे फिर आते हैं, नहीं जी डॉक्टर ने ब्लड प्रेशर मशीन आ गए, पल्स मीटर आ गए. आज के डेट में भी हमारे इंटीरियर्स पे इंडिया पे आप कहीं भी जाइए, वो ट्रेडिशनल ब्लड प्रेशर मशीन यूज़ होता है जो आज भी हम पसंद करते हैं. बट वी हैव डेवलप्ड इनोवेशन टेक्नोलॉजी. आपने एप्पल वॉच पहन लिया, एप्पल वॉच में पता चल गया. आज के डेट में अगर कहीं से कोई आपकी ब्लड प्रेशर मशीन पे बैटरी कम हो जाती है और आपकी बीपी हाई या लो आ जाता है, आप पेशेंट को बोलते हैं आपका बीपी तो कम है, पेशेंट विल नॉट स्पेयर. डॉक्टर साहब टेक्नोलॉजी तो आपने अपना लिया, मैं आपने ज़्यादा बीपी बोला, मैं तो दूसरे डॉक्टर के पास गया, वो तो बोले मेरा बीपी नॉर्मल है. सो वेयर वी स्टैंड? So there is something lacking. We are getting dependent on technology. I'm not against technology, but technology should go all together with the surgeon. I mean, very rightly said,
it's interesting that there's a divide, and
Yeah.
Dr. Indu is at the center of it, and I really like it there. That there are a set of people who possibly would be doing everything by robotics, and there's somebody who still believes that it has to be some conservation. There has to be some sticking to the base where it is. And so let them come back here.
Okay.
So we made some pertinent points that, essentially the patient has to get fine. Let both of them respond one out of the other. I think let Dr. Srivastava come in. So you are an innovator when it came to SS technologies. There is an Indian-based robot which is doing well, which has a considerable market share. How do you communicate to? Obviously, he is going to be your customer, right? Eventually, he is the typical person who will come across to your chamber and ask, "Why do I need to do this?" So I think you need to respond to this.
So I think first of all, you have to make the distinction, firstly, between a soft tissue surgical robotic system and the navigation systems that are used in orthopedic surgery. I know them very well because when I was in Chicago, I worked in trauma, and obviously ortho falls within this.
I think you need to speak into the
Yes.
mic.
Yes. Yeah, so I think one has to make the very acute distinction between a soft tissue surgical robotic system, which goes through basically laparoscopic sized instruments into the body to conduct majority of the surgical subspecialties minus neuro and orthopedics. To your point, and I agree with you, if you can do a knee replacement in 20 minutes versus 2 hours, the less exposure of nosocomial infections to the patient, obviously patient safety is paramount, and you have to consider this. I think the navigation systems in orthopedic surgery are far different than its application utilized in robotic surgery for soft tissue. But I also do agree that to your point, that as surgeons, as doctors, ultimately patients come to us to be healed. So ultimately the knowledge base has to be transmitted, and you have to maintain that relationship. Cost, of course, is very important, and I think as technology progresses forward, the trend has always been that the cost should come down, and if it doesn't come down, then there's an issue with that.
So,
I think, let's, because there are two other panelists. Yeah, please go ahead, but let's keep it
see, a robot is a very good technology in terms of orthopedics, in terms of joint replacement. Robot is something that tells us the accuracy of the surgery, right? But if you say he must be, if I'm wrong, he can correct me. So we are only just cutting the bone 2 millimeter, 5 millimeter, 9 millimeters. So only 5% of the job is done by a robot. 90% job is done by a surgeon who is an experienced one. So robot with an experienced surgeon, I think would give a better result rather than only depending on robot. If a person is not well equipped or not trained in a computer, you have the best of computer in the world, it's a waste. So the same way that goes with the robot as well, if I'm not wrong.
So I agree. So let's not make this entire panel about robot versus not robot, and I think let's give other panelists also a chance. And so coming to you, Dr. Sharma, 1 mg is possibly one of the largest in India pharma providers, online pharma providers. And so there are certain terms which I got to know in terms of the data management, and I thought they were out of Game of Thrones, IOMT, that Internet of Medical Technologies, which I don't know how do you go about using it. There's a blockchain, there's AI. So what I wanted to ask you about out of this is, how do you manage your data? You have huge amount of data coming from you. Is my data secure? Who has an access to those data? How do you utilize this data? There is a lot of consumption of that data can happen.
Thank you, Doctor. That's a very pertinent question, especially when we are talking of digital health and all kind of technology that are going through healthcare from top to bottom and bottom to top. When it comes to data, I think it's very important to know and what is happening at the back end. So when it comes to patient data, that's one part of the thing. When it comes to doctors, data that doctor is inputting on behalf of the patient, as well as there is a third or fourth kind of data which is admin data, and then data which is used for operational purposes like supply chain management and other kinds of efficiencies. So depending on the data type, if it's a patient data, it becomes important to protect it, and the highest standard of that is HIPAA compliance in the US. Most of the countries in some shape or form use that as the benchmark, and the DPDP Act that we are right now in the drafting stage in our country takes a lot of essence from the HIPAA compliance when it comes to healthcare data. So the data of the patient becomes of very, very important nature, and it has to be used with utter carefulness when it comes to within the organization, for the patient, for the cohort of the patient, or even utilizing for analytics purpose. That's one. Number two, when it comes to supply chain or admin data, that is used primarily for bringing out more efficiency. Let's say, for example, predicting demand, as well as preparing for that kind of demand when it comes to pharma products in a particular area or in a particular hospital for a particular kind of cohort, like it happened in the COVID times, where we were preparing for vaccines that need to be procured for different states in different quantity. So primarily data is managed with a lot of care within the organizations, and I'm sure that is true not just for core technology first organizations like Tata 1mg, but even for healthcare first and using technology as a tool organizations, which are all the hospitals, because there is definitely digitalization everywhere, wherein the data for the patient is secured, kept in an encrypted format, not to be used, not to be let out for the people to misuse it. It is probably used in a manner to enhance and give more accessibility, more choice, bringing more awareness to the patients. For example, we have something called health profiling or health insight that we are building, and it's one of the toughest problems that we are trying to solve using technology, where we are combining a lot of data points around a particular patient, and this is all happening within the gamut of encryption, security, and you said blockchain as one of them.
To that particular extent. So there are two questions which I have. It's just a leading question. Is 1mg partnering with any major healthcare to give back the data? Because if I understand the flow of the data as of now is doctor to patient to Tata 1mg, that would be the flow of the data as of now. Is the data being consolidated somewhere to come back to the healthcare which can help them manage the patients better? For example, a remote monitoring tool for chronic diseases, what drugs are being ordered, how can they be chosen better? That's one. And I think you should answer that, and then I'll come to the second.
Sure. No, I think fair, but as Tata 1mg is a B2C platform, we are not really letting the data out of the ecosystem. It's very well within the vaults of digital cryptography, let's call it. Having said that, that data is definitely used, like I was just saying, for profiling the patient. What I mean by that, let's say for example, if there is a patient and that patient buys a lot of diabetes medicines, that patient also does diagnostic tests, because that's another wing that we do. That patient reads a particular kind of information, then for that patient, we, to some level, we can see the trend of, what are his HbA1c levels, what are his glucose levels. We haven't done it, but we are in the process of integrating the variables, like you said, IOMT. So all kind of data and vitals that are coming from the variables, we are trying to put all of that data together and give, at least for the first level, patients some level of comfort. Like Dr. Das said, cyberchondria. So we are trying to relieve the patient of that, give him some talking points, which could be the outcome of it, of what he can go into a doctor's chamber and ask. Because most of the times when a doctor and patient interaction happens, patient is left with, this is the kind of prescription, this is the kind of drugs you need to take, this is the kind of physiotherapy, let's say, you could do one or two things, they're done. But at that moment in time, he's not prepared to ask, okay, if this is the medicine, then what does it really mean? Am I getting into some kind of cancer-related trouble, or is it just for pain, or is it a lump or a mass? So I think if you can have this kind of profiling for the patient, where at least it helps the patient to prepare for himself to ask that one question or two or three, which will relieve him of his own anxiety and his family. He can go back and then, so very simple example, and then it builds onto all kind of different use cases of prediction, therapeutics and all.
So what I hear from you is that the data is safe, and there is a background work going on to make it usable to the patients. This is where the thing is.
Perfect.
So coming to you, Dr. Poornima, and sorry, we took time to come to you. So as a doctor, what I do is I feed in my data into an EMR, and I still have a lacuna in terms of consumption of the data at a research level. So as an academia and as an academician, how do you go about utilizing the data which has been fed in well? That's the question number one which I want to ask you.
Okay.
The second question which I wanted to ask you is there a way the academia is bringing about a change in the mindset or in the way this intensive incentivization of the research happens? So essentially what I'm saying is, unless there is a partnership between academia and the industry, I don't think the real research is going to happen anytime. So what are your two thoughts on how does the data is best analyzed once it is put into the EMR? And second, how can the academia and industry work together so that there's an incentivization of the research?
Yeah, I'll come to your question a little later. First, yeah, thank you so much for the opportunity given here, and I represent the university called Sri Ramachandra Institute of Higher Education and Research, one of the best known health universities. So yeah, talking about data, and I mean, let me just give a brief on what is academic research going on in this innovation in healthcare delivery. Many research papers are coming out in the area of use of artificial intelligence in improving the patient outcomes, cost effectiveness, and also the long-term impact of these new technologies, that is artificial intelligence, telemedicine, as well as robotics. There was a debate between two people on robotics and traditional, but I should say the research supports the view that use of robotic results in better patient outcomes, and that is what the research says. The best, and not only that, the cost reduction over a long period, that is from the countries, that is developed countries, it's almost to the tune of $1.1 million. One study reported that the cost reduction is to the tune of $1.1 million. And as far as research is concerned, what we are doing is academic. So there is a lot of interest in conducting collaborative research. For example, I am again in a panel which in lung cancer prediction, where there are two doctors, two computer scientists, as well as two management professionals like me, where we do the data analysis. Right now, we are using different algorithms, that is convoluted neural network is used to actually have a machine learning, and this is regarding the collecting the data, which is already there. I mean, we are right now in the testing phase, and the computer scientists are saying which algorithm is best suited, and we data analysts say that consolidate the results and say where the data is available. And regarding the research, the research is also looking at what are the training needs of healthcare professionals, because basically when pre-COVID and post-COVID treatments are vastly different, suddenly the doctors have to understand about artificial intelligence, data analytics, and machine learning. So our university as such has strived to bridge this gap. In fact, there is a talk in the council, about academic council, that the medical education should also have papers on data analysis as well as the machine learning. So we have tied up with IIT Chennai, and that is what is going on. And not only that, coming to the cost benefit analysis, we have tied up with ICMAI, when we have started a certificate program in healthcare finance, where the need was felt because the doctors did not know much about costing, and the finance professionals did not know the intricacies of healthcare. So we have already run 2 batches to make it more efficient and taking into effect the costing, and so these are the things for academia is doing to upskill and reskill it.
Thank you. So, I think we just 5 minutes left, and there are a few points which I wanted to bring about. So, Dr. VIPIN, what has been rather interesting is that a lot of technological consumption still happens in the metro cities. And as a urologist, I'm sure you have your peers across the country. How do you think that we can widespread this or democratize this entire consumption of technologies in terms of both the robotics as well as the upskilling? Go ahead, and then I would like to ask Dr. Indu, still the Linacs has possibly come into the Chennai, Delhi and Mumbai's of it. The premier institutes sitting not in the metro cities do not have those machines. What do you think are those challenges and the possible solutions there? So we'll start with you, Dr. VIPIN, and then.
So the first of all, technology is something which we cannot avoid. I always say that you have to improvise, otherwise you need to compromise. So technology is essential for the metro cities as well as tier 2 and tier 3 cities. Now the responsibility lies with us and with Dr. SRIVASTAVA with their SSI innovations, that we have to send a message to all the tier 2, tier 3 people that there are cases which can be done with the advantage of this technology at a cost which is affordable in those cities. And that's where the role of SSI Mintras and Made in India robots come into the picture, because they are the robots which are affordable and they are moving towards that. Now we have robot available in Muradabad, we have a robot available in Bareilly and all those tier 2 cities. Regarding the technology spread is, you have to be justified. All the cases does not meant for robotic surgeries. There should be a justification for the patient, for the surgeon and for the society at all. So if there is something which is complex, there need to be a hub and spoke system, that there are a group of patients which can be referred to the metro cities for the definitive treatment. Now in the robotic urological arena, which I deal with, all the cases are not complex. If you're treating a radical prostate or doing a robotic surgery for cancer bladder, these are much complex surgeries and need to be referred to a metro cities. But if you're just doing a pyeloplasty or doing a ureteric reimplant or just doing a small reconstructive surgery, that can also be done at tier 2 cities. So the justified distribution of the knowledge and the technology is is necessary right now in our country. That a radical prostate cannot be done, and the patient will also not get it done at a city in Muradabad.
So that's what we are trying to bring a change about.
Yeah.
And that's what I'll come to you, Dr. SRIVASTAVA, about it. Let's Dr. Indu come in for the radiation and then we'll ask Dr. SRIVASTAVA.
I think I would say that now that good number of Linacs are coming in tier 2 and tier 3 cities as well. Proton treatment is now also available in Bombay. Now the thing is, the cost of these investments is huge. It's around say 300 billion or something for a proton setup. So if with the technology, the cost also comes down, say, and the space requirement for these technologies, it also comes down. Now like the Linacs are becoming much smaller. They're becoming more compact. So they can be fit in a small area. Earlier they would take a lot of spaces. So I think what I see that the future of healthcare is basically focused on digitization, prevention, and of course early detection of cancer. So these are and personalization. I think these are the 4 key elements that will determine anything about the healthcare. So I think it's the responsibility of people like us, or the people who are my seniors and all, that we have the responsibility to educate the juniors who are sitting in the or to educate the general public or plain MBBS doctors or other people to at least detect cancers in the remotest of places, and those patients, we can have a virtual consultation with them, and those patients then can come for
all of us
treatment.
are talking about a hub and spoke. So let me ask Dr. SRIVASTAVA. I think, see, you spearhead SS innovations, and I think considering that you are from a very business point of view, how do you spread it out? As in, we all understand, Dr. VIPIN and Dr. Indu, I think they were all speaking that it eventually will be hub and spoke. But then we are trying to break the hub and spoke is what we are trying to do. So what are your thoughts about in that particular?
I think that, see, a lot of it comes down to ultimately what training has gone into, back to your original question. And I think, also agreeing with Dr. VIPIN, that some of these more complex procedures, obviously the level of training in these metro cities, they've had the robot for quite some time now. Although, there are instances where, see, if you look at just the clinical cases that we've done, majority have all been complex procedures. And a lot of them have been done in tier 2 and tier 3 cities, and that has to do with the training. Of course, if someone's doing a radical prostatectomy, obviously that's not the first case that we recommend that they do. There has to be a gradual progression, coming up to that. But even in countries like Nepal now, they've done, I think, 4 or 5 radical prostatectomies. Of obviously, initially with a proctor, and you follow the process. But see, it is possible. And initially in some of these, anecdotal examples I've utilized, the operative times were much longer than what, but same as when someone begins their training, their operative times will be longer. So see, there's an evolution and a gradual transition that has to occur. Today, I think Dr. TYAGI is absolutely right. Majority of these are happening in the metro cities. We're trying to break that, as you pointed out, so that we can start offering such complex procedures in smaller parts and more remote parts of the country.
Thank you. So I think we are out of time and we'll just summarize and take homes. So we started with Dr. INDU. You said there has been definite improvement in patient outcomes, and there's no doubt about that. And essentially, there has to be an honest conversation with the patient, which will probably lead us to where we are. Dr. Prasad, eventually we pulled in, and we do realize that robotics will be required, not for every case, but it will be required. And while keeping Dr. Das's point of view is that not everything does require a robot, and it has to be a conscious call by the doctor who is the treating surgeon or the physician to bring in how much does the patient need a robot. I think that's where we are very clear about it. We went on to Dr. Rajeev, and we have kind of agreed that the data is safe, the data is being read, maybe blinded by the company to improve the patient outcomes. And I think to end it, Dr. POORNIMA does suggest that there's a lot of academia, still academic partnerships. I still do not see academia industry partnerships coming in which can incentivize the research. And I think that's what the lacuna is. And with that, I'd like to thank all of you for being part of such a fabulous panel discussion. And thank you so much. And from there, we'll wrap it up.